Hey everyone. Can you guys hear me okay?
Yeah.
Okay. All right, thanks for everyone who decided to come. I know it's not required, for you to be here today, but I just thought it might be better for us to go over some of our material so you don't get too far behind since we're missing a whole week. So what I want to do is go over acid-base stuff with you today. So if you can, everyone just mute yourself so I don't hear any of the background noise, and I'll just try and get through this real quick. If you have a question, there's a chat thing at the bottom that you can, say something there. So feel free to do that if you need to. All right, I'm gonna try and share my screen here. Can you guys see that okay, I hope? All right. So I don't know if you guys have notes or whatever paper that you can write some things down as we're going through this, but if you do, why don't you go ahead and write down these values? So when we talk about ABGs, a normal pH level is going to be between 7.35 and 7.45. The other two values that you look at when you do an ABG is going to be the PaCO2 level, which is going to be 35 to 45. And then also the HCO3 level, which is 22 to 26. There's another level that I want you to write down. This one, you don't really need this level to figure out an ABG, but it's just nice to know the information because it's going to tell you if this person is having hypoxemia or not. So PaO2, write down 80 to 100. Okay. Another thing I want you to write down, there's a mnemonic. It says ROME, R-O-M-E. So R means respiratory, O means opposite, M means metabolic, and E means equal. All right. So let's go ahead and get started with this. So hopefully you can see this PowerPoint all right. I'm just going to kind of go quickly through these slides with you so you know what's what. All right, so for acid-base imbalance, one of the first things that you might see if someone has an acid-base problem would be a change in their normal breathing pattern. So interventions and diagnostic testing like ABG analysis are performed to identify the source of the imbalance to figure out how best to treat it. So pretty much in our body likes everything to be in homeostasis. So if we don't have everything, in a way that it wants it to, things aren't going to function correctly. This means like down to the cellular level, down to the organ level, everything's going to be off. So it's really important to get things back to normal. All right, so the ABG is the most commonly used thing to evaluate acid-base imbalances. So the pH is just going to be the expression of the balance between carbon dioxide, which is regulated by the lungs, and bicarbonate, which is a base regulated by the kidneys. So the greater the concentration of hydrogen, the more acidic the body fluids are, and the lower the pH. And then the lower the concentration of hydrogen, the more alkaline everything is. And then, the higher the pH. So when you're looking at these ABGs, the major clinical manifestations of an acid-base imbalance are indicative of central nervous system involvement. And then how bad this person is going to depend on the length of time that they were in this ABG imbalance. So if I had a pH of 6.8 whatever, and I was in that for a long period of time, I'm going to be pretty darn sick. Whereas if maybe I just had maybe a 7.2 pH, maybe I wouldn't be as sick, is what I'm trying to say. Okay, so our body has these different mechanisms that kick in to try and help get everything back into balance. So we have things called chemical and protein buffers, we have respiratory buffers, and we have kidney buffers. So I'm going to go into detail about some of those now. So the chemical and protein buffers would be something that happens pretty quickly. So if our body detects that we're out of sync with our pH, if it detects that you're acidic, or if it detects that you're alkalotic, it's going to kick in pretty quickly to try and fix this. So the primary chemical buffers are sodium bicarb and carbonic acid. So carbonic acid would be, the acidic portion, and then sodium bicarb would be the alkaline portion. So if you think about it, if your body detects that you're too acidic, what's it going to do? It's going to kick in and give you some sodium bicarb to like neutralize that, to get your pH back to where it should be. And the opposite would happen if you were too alkalotic. So if you were too alkalotic, then your body would kick in and give you some more carbonic acid to bring your pH back to normal. So that's kind of how that part works. The next one is the respiratory buffers. This is your second line of defense. So what this does is it kind of controls the way that you breathe. And in that sense, it will affect your hydrogen ions. So basically, if you have hyperventilation, it's going to decrease the amount of hydrogen ions that you have in your system. And what's it mean when you hyperventilate? You're breathing really quickly, right? So hypoventilation is going to increase your hydrogen ions. So if you're not ventilating good and you're not breathing well, you're not oxygenating well, then those hydrogen ions are going to increase to try and fix that. So basically, your respirations are going to increase when you have decreased CO2 levels. And this is going to increase your pH. Your respirations are going to decrease and cause retention of CO2, and then cause your pH to decrease. So those are the two things that would happen with the respiratory buffers, depending on what you have going on. So another thing I wanted to mention here, if your respiratory system is the source of the pH alteration, then it loses the ability to correct the problem. So if you have like, I don't know, pneumonia or something like that going on, and you have this issue with your lungs aren't going to be able to kick in to fix that then, because you already have an issue with your lungs. All right, the other buffer is your kidneys. Okay, so with the kidneys, this is the third line of defense, and this does not kick in as quickly as the other two do. So usually it's going to take about 48 hours to make any type of change with your kidneys. So the kidneys reabsorb sodium and produce and conserve sodium bicarb. So this is what happens then. If you have too much hydrogen ions, so if you have an increased amount of them, if you're too acidic, then bicarbonate is going to reabsorb and you're going to produce more, because you want the bicarbonate to like neutralize the acid. If you don't have enough hydrogen ions, then you're going to have bicarbonate excretion. So this would be in response to alkalosis. All right, something that's really important that I want you to write down if you are taking notes. This is something that kind of will help you with certain test questions. So if you have someone that's in acidosis, they have increased hydrogen ion concentration because they're in acidosis. So they're going to have hydrogen ions that are excreted before potassium ions. So it's going to precipitate hyperkalemia. So that means anytime you see someone on a test question that's in acidosis, that means they're also going to have a high potassium. So any type of acidosis, whether it's respiratory or metabolic, they're always going to have high potassium associated with that. And then the opposite is true with alkalosis. So anytime you see alkalosis, whether it's metabolic or respiratory, you're going to have low potassium, so hypokalemia. Okay. And also, I just wanted to mention too, with any of these buffering systems, like whether it's your kidneys or your lungs, if you have issues with those, then your buffering system isn't going to kick in and work. So, like if I have kidney failure or chronic kidney disease, I am not going to be able to have my kidney buffer kick in to fix this. It's not going to be able to do that because my kidneys aren't working as good as they should. Okay, so that's the buffering systems that we have to try to get our body back into, balance with our pH. So then we're going to go into the different disorders. There's 4 of them. The first one is respiratory acidosis. So when you have respiratory acidosis, this means that your pH is going to be below 7.35. Your PaCO2 is going to be high. And then your HCO3 is either going to remain normal or most of the time it's going to be normal. We'll just leave it at that. All right, so when you think about respiratory acidosis, I want you to think about hypoventilation. If we had class today, I would have given you guys this, which I'll see if I can go ahead and put that online for you. But basically, respiratory acidosis is characterized by someone hypoventilating, causing hypoxia. So this means that something is making them not be able to oxygenate like they should. So some of the examples of causes of that I have on another slide here that I'll get to in a second. But yeah, so hypoventilation, respiratory acidosis. So if someone is not breathing well, they are going to have elevated CO2 levels, right? So they don't have enough oxygen, so they're going to have more carbon dioxide. So they'll have hypercapnia. They also are probably going to be breathing pretty quickly because they can't get enough oxygen. So usually when you can't breathe, you do that. They could have a lot of anxiety associated with this. They could have an elevated respiratory rate, an increased pulse, an increased blood pressure. And then what did we just say about potassium? Because this is acidosis, you're going to have too much potassium. You could also have like a headache associated with this, maybe hyperreflexia, disorientation, those types of things. So here are some of the causes of why you might have hypoventilation. So they're kind of, I think they make sense. So things that would make you not be able to breathe well. So, hey, I have a PE, an acute pulmonary embolism. I have aspirated something like a foreign object, like I don't know if your kids have ever swallowed anything they're not supposed to, but like something like that. You would be worried that they wouldn't be able to breathe well at some point if that got caught in their respiratory system. Pneumothorax, sleep apnea, pneumonia, acute respiratory distress syndrome, any of those types of things would cause you not to be able to breathe well. And then I really want to call your attention to the bottom of this. This talks about different muscular problems like muscular dystrophy, multiple sclerosis, myasthenia gravis, and that Guillain-Barré syndrome. All of these things are things that cause your muscles to be kind of weak, I guess you could say. Especially like this muscular dystrophy. I have a sister-in-law who has this, and she's had this since she was 12. And when she was young, she was still able to do quite a bit, but now as she's older, her muscles are getting worse and she's not able to do as much. So now she has more difficulty breathing and has to be on a CPAP at times because of that. So when we talk about treatment then of respiratory acidosis, all we have to do is try and fix this problem, whatever is causing them to not be able to breathe well. So if it's pneumonia, then we're going to give them antibiotics and we're going to give them breathing treatments. If it is a PE, we're probably going to give them anticoagulants. Whatever the cause is, you need to figure out the cause, and that's going to fix this problem. So that's how you would treat respiratory acidosis. Okay, the next one is going to be respiratory alkalosis. Okay, so with respiratory alkalosis, we're going to have a high pH and a low CO2. This is going to be characterized by hyperventilation. So I'm sure you've all seen someone hyperventilate before. What do they look like? They're breathing really fast, they're really anxious. That's what I want you to think about when you think of respiratory alkalosis. So look at some of our signs and symptoms. We have tachycardia. We have inability to concentrate. We have lightheadedness, decreased cerebral blood flow. Sometimes people will even get a loss of consciousness, ventricular and atrial dysrhythmias. All of those things might play a part here. Okay, so what would be some of the causes of why someone would have respiratory alkalosis? So anxiety is your number one thing. Hypoxemia. So remember back when we just talked about respiratory acidosis. So those people are not oxygenating well. So you could go from that to this in a way. Other things that might cause this would be, cerebral tumors, inappropriate ventilator settings, maybe you have salicylate intoxication. Any of those types of things would be why you would be in this. All right, so pretty much with all of these acid-base problems, if you treat the underlying problem, it fixes the acid-base problem. So if this is someone who is anxious and that's what's causing them to be in this, then maybe you have them breathe into a paper bag, or maybe you give them anti-anxiety medication. If this is someone who has some type of brain tumor, if you have surgery and have that brain tumor removed, that's going to fix this problem. So whatever it is, that's what we have to do. Okay, then we get into metabolic acidosis. So metabolic acidosis, you would have low pH and a low HCO3. So with this is one that you see a lot with diabetic ketoacidosis. So there's quite a bit that happens with this. So I don't want you to get too bogged down with like knowing what diabetic ketoacidosis is and all of that. But I'm going to tell you a few different things about this that I think you should kind of remember. Okay, so with this, there are a few different things that can cause it. So there's something called an anion gap that people will calculate to figure out what the cause is. So the anion gap has this formula that's listed right here on the slide that I would not expect you to know or do, so don't worry about that. It's just FYI. So it has this there so that you can figure out what the cause is. So after you read this, it'll make more sense. So just take a look at that and that'll make sense. All right, so with signs and symptoms, I don't know if you've ever dealt with anyone in diabetic ketoacidosis, but a lot of their symptoms are kind of weird and different. So a lot of times they will get really confused. They will have sometimes abdominal pain, a lot of times nausea and vomiting, a low blood pressure. They sometimes will have like warm, flushed skin. They can have something called Kussmaul respirations. What Kussmaul respirations are is just an increased rate and depth of your breathing. And again, because this is acidosis, you're going to have a high potassium. And then you could have like decreased reflexes and stuff with your muscle tone and everything. You could have dysrhythmias and stuff too. So other things that could cause this other than diabetic ketoacidosis would be starvation. So if you were on some type of starvation diet, or heaven forbid you were somewhere like a concentration camp or something like that where people were starving you on purpose, you could go into this. Liver failure could cause this. Pancreatitis, kidney failure, lactic acidosis, an excessive intake of acids like alcohol or even aspirin. So then to treat this, if it's diabetic ketoacidosis, you're going to give them IV insulin, which would be regular insulin. That's going to be one of the main things that you do first. Bicarbonate can be given because remember they have too much acids on board, so maybe you would give them bicarbonate to try and neutralize that. You're going to try and treat their potassium level as well to get that to come down. You want to treat low calcium levels before the acidosis to avoid tetany. And then also, if this was like someone who had liver issues or something along those lines, or kidney failure, maybe you do dialysis and that's going to treat the problem. Okay, so our last one is going to be metabolic alkalosis. Okay, so with this one, you have a high pH and a high HCO3. So this one, this one is going to have some like GI type symptoms as well that's associated with it. So you could have decreased motility and a paralytic ileus as a result of this. This person could have lots of nausea or vomiting and diarrhea. They could have dysrhythmias because of the low potassium, anxiety, seizures, anything like that. So metabolic alkalosis is going to be because you have too much base in your system. So this could be because you took in too many antacids. It could be because of other things like TPN or Maybe you just have an acid deficit because of maybe you have an NG tube in and they're doing lots of NG suctioning or something. Could be from any of those types of things. Even digitalis toxicity, that could cause this too. So again, your treatment is going to vary with the cause. If it's due to GI losses because you were just sick and you were vomiting and all of this, and that's why you have alkalosis, then you're just going to replace their fluids and their electrolytes. Give them antiemetics, whatever you need to do to fix that. And then always we're going to treat their potassium level. If they're too low, we're going to give them some potassium to get that to come up. Okay, so this is where it gets kind of interesting. So the last part of these slides is just about how to figure out what an ABG is. So for this part, I want to kind of look at some of those videos with you real quick, and I won't show all of it obviously because I don't have time. But you need to figure out how to figure these out on your own. In your ATI book, chapter 45 is all about acid-base imbalances. On page 283 is a great page for you to be looking at because it talks about step-by-step how to look at an ABG, and it also has the whole thing about if it's compensated or not compensated, which most people really have a hard time with. All right, let me see if I can get on a different thing here. Okay, so I kind of like this particular video here. I'm going to show you just a little bit of that real quick because he shows you how to set up the ABG tic-tac-toe. And then I like how he has all of his stuff written over here on the side because it helps you be able to figure out things a little easier as well. So bear with me a second. I'm going to see if we can play this real quick. It looks like I have 10 minutes before this kicks me out. So.
Okay, we're just going to be working through some extra practice problems here on reading ABGs. These problems I have here are available on this website, survivenursing.com/ABG. This will generate 10 different ABG practice problems that you can do, and whenever you're ready, you can just click show answers, and you can check your results. So let's just go ahead and work through these 10 so you can get some more exposure to this. So number one, we're going to draw our tic-tac-toe grid. So tic-tac-toe. This column is acid, this column is normal, and this is base. So we go ahead and we look at our first problem, 7.79. Our pH is 7.79. It is basic, it is alkalonic. So we write down our pH in the base column. We look at our CO2, it is 24. It is also a base, so we write down our CO2 in the base column. Our bicarb is 21. It is acidic, so we write down our bicarb in the acid column. So our tic-tac-toe was formed with these three parameters. So since it's in the base column, we know that we are in alkalosis of some sort. Now we need to look to see which parameter made up our tic-tac-toe, in this case it's CO2, and remember CO2 is a respiratory value. So we are in respiratory alkalosis. And then we need to see the opposite parameter. So in this case, we use the respiratory parameter to make our diagnosis. So we look at the opposite parameter, in this case, our metabolic parameter, and which column it's in is the acid column. So this means we are partially compensated.
Okay, so again, when you're figuring out these problems, you need to draw your tic-tac-toe. You put your acid, your normal, your base here. And then all you do is look at the pH first and you decide, hey, is this alkalotic or acidotic? And that's why I like how he writes his up here, because if you do that, you're going to figure it out just right. So that's why you just write pH here under the base column. Then you look at your CO2 and look, notice how he wrote his CO2. He wrote it backwards, 45 to 35. This is because you remember that thing I told you to write in the beginning, that ROME, respiratory opposite metabolic equal. So respiratory is opposite with the acid base stuff. So that's why if it's low, it's going to be basic. And if it's high, it's going to be acidic. So that's why if you write it that way, it'll be better for you. And then it's the only one that's like that. Everything else would be the same as like just looking at your pH and everything. So with metabolic 22 to 26, if I have something higher than 26, it's going to be basic. If I have something lower than 22, it's going to be acidic. Now with the compensation stuff. So again, look on page 283 in your ATI book, and it goes over this in step 5. This is just something you kind of have to memorize, I think, to really understand what's going on. All of those different buffer systems that we talked about earlier, that's what we're talking about with compensation. So is any of that kicking in? So if someone is uncompensated, that means the pH is outside of the expected reference range, and either the HCO3 or the PaCO2 is outside the expected reference range. If you're partially compensated, like this problem here, the pH, the HCO3, and the PaCO2 are outside of the expected reference range, so nothing is normal. And then with full compensation, you would see the pH back to normal. So the pH is going to be in the normal section and everything else is going to be not right still. So that's something that you just need to work with. Okay, so let me get out of this one a second. Let me show you what it looks like when you do a full compensation problem.
Okay, we're going to be working through some more ABG practice problems. This time we're going to be focusing in on full compensation. We're getting some messages saying that people have been having some troubles with this concept. So let's go ahead and just dive right in and work through a couple of these examples. So let's say we have a pH 7.36, PaCO2 of 30, and a bicarb of 15. Okay, so the first thing we do is we look at our pH value, 7.36. We see this is normal, so we write in the normal column. Our PaCO2 is 30, which is basic, so we write our PaCO2 in the base column. And then we look at our bicarbonate, 15. 15 is acidic, so we write this in the acid column. So now it's time for our diagnosis, but remember now that our pH is normal and the other two values are abnormal, we have a case of full compensation. But now we need to look to see our pH and see which side of 7.4 does it fall on. So 7.4 is in the middle here. 7.36 is less than 7.4, so it is closer to the acidic side. So this means we are in fully compensated something acidosis. And then we look at our acid dose or our acid column and see which parameter is in it. In this case, it is our HCO3, which is our metabolic parameter. So we write down metabolic, and so this means we are in fully compensated metabolic acidosis. So our primary condition is metabolic acidosis, but our respiratory system is able to fully compensate enough that the pH is now back into a normal range.
Okay, so this is going to kick me off here in about 2 more minutes. So real quick, if you want to unmute yourself, if anyone has anything they want to ask me, go ahead and do that real fast. If this cuts me off, feel free to go to the chat room inside of Canvas in our class and you can ask me there. Again, make sure you use some of these extra resources that I give you. Use all of these videos to practice some of these things because you're going to have problems like this on your test too. Also, you could go to Picmonic if you wanted to. Picmonic has a lot of stuff about this, about the different disorders like the respiratory acidosis and metabolic alkalosis and all of that. You could also go to registerednursern.com. She's got a bunch of questions that you could do about these. As far as practicing ABGs, she has that. She has a whole thing about doing these problems that you could watch her videos. There's a ton of stuff, so feel free to do that. As far as other stuff with our class goes, our normal class time now will be, Tuesdays and Thursdays. Typically, we would start at 8:30, but I think I'm going to just start at 9 from now on. It just makes it a little easier, I think. So plan on coming on here about 9-ish, and we'll be doing, something similar to this on Tuesdays and Thursdays. Make sure you look at your discussion board. I'm going to put something on there today that I want you to comment on, and that's part of our class time as well, doing the discussion board. I also put some things on there about you're doing case studies instead of your clinical worksheets. So those are on there for you to do. If you just want to write out the answers and send those to me, that's fine. I also put on an alternative care plan for everyone to do if you didn't get a patient at clinical. If for some reason you already had a patient and you have enough information to do a regular care plan, then that's fine. But I had to do something different for everyone else, so that's what that's about. And as far as clinicals go, you guys will be starting to do clinicals this coming week online in a different format. So you should be getting information about that really soon here. It looks like a really neat program, so hopefully it'll be fine and everyone won't have a